Every month, millions of women experience symptoms right before their period, such as mood swings, cramps, bloating, irritability, and fatigue. For some, it's uncomfortable but can be managed, while for others, those days become the darkest part of the month emotionally, mentally, physically, and psychologically. Today, we are diving deep into one of the most misunderstood topics in women's health, which is PMS versus PMDD. We are going deep into hormones, neurotransmitters, and what every woman needs to know to protect her mental health in the long term. And by the end of this video, you will never confuse PMS and PMDD again. So premenstrual syndrome is a combination of physical and emotional symptoms that happens during the luteal phase, which is the period after ovulation and before your next menstrual bleeding. PMS is common, mild to moderate, can be annoying but not disabling. It's caused by hormonal fluctuations, and sometimes up to 90% of women experience this to some degree. PMDD is classified under depressive disorders in the DSM-5 manual. It causes extreme emotional and psychological symptoms. It can interrupt work, school, and relationships. It can create suicidal thoughts in extreme cases, and it affects 3 to 8% of women globally. It is triggered by the same hormones as PMS, but in this case, the brain reacts differently. The key difference between them is PMDD is not a hormonal disorder as PMS. It's a brain-sensitive disorder. Your hormone levels are normal, but your brain's reaction to those hormones is what is abnormal. In PMS, it happens due to changes after ovulation. When the egg is released, progesterone levels rise and estrogen dips slightly. If conception doesn't occur, both hormones crash, and this hormonal rhythm affects serotonin, GABA, fluid balance, prostaglandins, cravings and appetite, stress response, and breast tissue sensitivity. PMS is basically your body responding to normal hormone waves, and its symptoms include bloating, breast soreness, acne, cramping, irritability, mood swings, food cravings, increased appetite, and mild fatigue. With PMDD, the hormones are normal. There are no excess estrogens, no deficiency of progesterone, and no strange hormone levels. Women with PMDD have abnormal serotonin reuptake, low serotonin resilience, altered GABA-A receptor response, high sensitivity to progesterone metabolites, changes in the estrogen receptor 1 and changes in the estrogen receptor gene 2, and there is a dysfunction in the brain's emotion regulation network. This means the brain literally reacts as if progesterone is a threat. And during the luteal phase, progesterone rises. The brain of a woman with PMDD interprets that rise as a destabilizing event, which creates intense sadness, severe rage, panic-like anxiety, emotionally overwhelming, sudden crying spells, feeling out of control, and thoughts of hopelessness. These symptoms can be so severe that so many women describe it as, or in the words of a patient I know, I become a different person before my period comes. I become unrecognizable. PMS symptoms are mild to moderate, causing bloating, cramps, mild mood swings, fatigue, mild irritability, increased appetite, and breast tenderness. But in PMDD, there is severe depression, sudden sadness, feeling overwhelmed, hopelessness, rage or uncontrollable anger, extreme irritability, panic or anxiety, difficulty concentrating, severe fatigue, insomnia or hypersomnia, binge eating, feeling out of control, low self-esteem, and thoughts of self-harm in severe cases. These symptoms start after ovulation. Its peak is between 1 to 7 days before bleeding. It disappears once menstruation starts and comes back every cycle, causing functional impairment or affecting activities of daily living, such as missing work, cancelling plans, withdrawing from loved ones, losing control emotionally, inability to care for yourself or others. PMS is diagnosed clinically based on symptoms, and the symptoms must occur in the luteal phase, resolve with menstruation, not impair daily life, and no special tests are required. But for PMDD diagnosis, it requires daily symptoms charting for at least 2 cycles using the daily record of severity of problems. Secondly, at least there should be 5 symptoms, one of which must be severe, causing impairment, and must occur only in the luteal phase. Laboratory tests will show normal hormone levels, and this is why PMDD is often missed. Lifestyle interventions for PMS include regular exercise, eating balanced and anti-inflammatory diets, great sleep hygiene, stress reduction techniques, limiting caffeine, alcohol, and incorporating supplements that would help with the condition, such as vitamin B6, magnesium, calcium, omega-3 fatty acids. Also, medications that could help with alleviating the pain are NSAIDs for cramps, hormonal birth control to stabilize the cycles, selective serotonin reuptake inhibitors in rare cases. Now, for the management of PMDD, it needs more medical level advanced treatment because this is a neurotransmitter disorder, not a hormonal problem. Selective serotonin reuptake inhibitors such as fluoxetine are the first line of treatment for PMDD and can be taken daily or only during the luteal phase because SSRIs dramatically improve serotonin balance, mood, and emotional regulation. Secondly, hormonal therapy is also added, especially drospirenone containing pills and GnRH agonists for severe and resistant cases. Thirdly, CBT, which is the cognitive behavioral therapy, because it improves coping with emotional spikes. Fourth, you have the lifestyle, which includes anti-inflammatory diets, regular exercise, stress reduction, sleep regulation, and alcohol avoidance. For advanced options or in severe cases, ovarian suppression therapy is used. Surgical oophorectomy, this is extremely rare, but done and only after all options fail. Because PMS and PMDD are cyclical, prevention focuses on stabilizing the brain's hormone interaction. Key strategies to improving your health long-term are: eat balanced meals to stabilize your blood sugar, reduce inflammatory foods, prioritize your sleep, avoid excessive caffeine, journal symptoms, track moods and cycles, manage stress intentionally, and use therapies consistently, not occasionally, because PMDD needs consistent care. It cannot be prayed away, ignored, or pushed through. Now, let's summarize their core differences. PMS is hormone-driven. Symptoms are mild to moderate. There are no major mood changes, no functional impairment. But in the case of PMDD, it's a brain sensitivity disorder. There's severe, intense emotional symptoms, it requires diagnosis, treatment, and can impair daily life. If your symptoms disrupt your life every month, it's not just PMS. Your brain is responding differently to hormones, and treatment can completely change the quality of your life for the best. Understanding these differences is the first step to protecting your mental and reproductive health as a girl. If you found this video eye-opening, helpful, and educative, share it with every woman you know because PMDD is massively underdiagnosed and knowledge saves lives. Thanks for watching Mira's Health Hub. I'm Mira and I'll see you in the next video. Bye-bye.